everyone, and welcome to Functional Fertility, the podcast designed to demystify your hormones, up-level your lifestyle, and supercharge your fertility potential. I'm your host, Dr. Kalea Wattles, and today I'm excited to take a deep dive into the realm of holistic fertility, exploring unexplained infertility and recurrent pregnancy loss. Joining me today is a treasured colleague of mine, Dr. Aumatma Simmons. Dr. Aumatma is a double board-certified naturopathic doctor and endocrinologist in practice for close to 15 years. She's the best-selling author of 2 books, Fertility Secrets, What Your Doctor Didn't Tell You About Baby Making, and Infertility, Struggles, Secrets, and Successes. Dr. Aumatma is the creator of Fertile Foundation Supplements, host of the Egg Meets Sperm podcast. She's a speaker, she's an educator, she is an all-around force in the field of integrative and holistic fertility. Welcome to the show, Dr. Aumatma.
Thanks for having me, Dr. Wattles.
Well, your practice is the Holistic Fertility Institute, and I thought we better lay the groundwork at the beginning of this episode and allow our listeners to hear from your perspective. What is holistic fertility?
Yeah, that's a really good question. I think back in the day when I established this, I really came into naturopathic medicine with a love for mind, body, and spirit, like an integrated human, right? And we are integrated humans. What I think is unique about fertility is it really also needs to be the mind, body, and spirit of our partners. And for me, that's really what made it holistic, is it's me, all the layers of me, and then my partner and all the layers of my partner, and how we interact is all impacting our future babies.
That's beautiful, because when I think about this concept of holism, that is how I think about it. It's all these layers of us and of those around us and the networks we're part of. And so it sounds like that was your thought process around just the holistic aspect.
Yeah, exactly.
Well, I know that you work with a similar patient population that I do. And so I would imagine a huge percent of your patients have been diagnosed with unexplained infertility. Am I getting the sense that is true for your practice too?
Yeah, and what does that even mean? But yes, a lot of people come in with like, I don't know, it's unexplained. No one's telling me what's happening. So yeah, that's a really big percentage of the population.
And what a frustrating diagnosis. You and I have talked about this before, so frustrating. And so that's where we come in. And I always feel like this is our time to shine, because we are trained to ask the right questions, to take a thorough history, to think outside the box, to use that holistic approach. Systems biology is how I often, but it all means the same thing, right? Holism, systems thinking. I want to start with the lab evaluation, because I would say the majority of questions I get in my DMs on Instagram or into my email are about, what labs do I need? There's so many different strategies and panels and companies that are available. So in your practice, will you give us a rundown of, when someone has unexplained infertility, what are some of the most important labs that you're ordering right away for pretty much everybody?
Yeah. So I think everyone ought to start with the basic 4. AMH, FSH, LH, estradiol, right? Done on cycle day 3. A lot of people don't get told to do those on cycle day 3. So I'll look at it and then there's a progesterone on there, and that's an obvious kicker of like, yeah, that's not the right day. If you tested progesterone, it's not the right day. So it really, like, making sure that they're done on cycle day 3 so that you can have a real view of what's happening on the baseline. That's not to say that no other part of the cycle is important, but if you're trying to understand and evaluate what's happening with your fertility, you need those hormones on cycle day 3. And we can get into, like, just on the surface, even those will give us lots of information. I had a woman with unexplained infertility times 7 years, been to 3 different IVF specialists, 6 rounds of IVF, 39 years old. So she started this journey at 32.
Yeah.
And she was told unexplained infertility. I took one look at her day 3 labs and I was like, has your estrogen always been this low?
Mm.
And she starts weeping and is like, what do you mean?
I didn't
Like,
go and
I've been
see
through
anything.
so many doctors, right? And like, if you're going to tell someone it's unexplained, then there better be a reason for it. But instead, here I am looking at her estrogen, like, there's no way you could be pregnant. Your estrogen is 7. That's menopausal. Like, your body thinks it's in menopause if you don't have estrogen. And then we did a Dutch hormone test, which is a cycle map test for urinary hormones, which I'm sure you do a ton of.
Yep.
Uh, and we do that, and her estrogen's flatline the whole cycle. And I was like, yeah, your body just has no way of producing estrogen. She runs on cortisol. There's a whole bunch of stuff that was just off in her labs. And the indicator was that estrogen on cycle day 3, right? So that cycle day 3 is just so important. And I think because we have so many complex tests now and we can like do this test and that test and that test, we forget the basics.
Mhm.
So I always like to start with the day 3.
Yeah. Well,
Um,
can I just pause really quick before you
yeah.
move on? I'm like taking notes over here. I'm thinking, don't forget to go back. I'm so happy that you gave an example of low estrogen because I think, I don't know, I think it's, social media and all these articles where we read,
Mhm.
everyone is pretty hyper focused on estrogen
High
excess.
estrogen. Yeah.
Yeah. And
Yeah.
so I think we sometimes miss if estrogen is too low. And we have to remember, like, estrogen is what is responsible for thickening that endometrium, for giving you that egg white cervical fluid. So if your estrogen is really low, there's going to be some big fertility implications.
Yeah.
So, thank you for looking at that. I'm so glad you did that. Um, will you give us maybe just a snapshot of like a couple of your go-to interventions or strategies when someone has low
Mm.
estradiol?
Oh, that's great. One of my favorite herbs of all time is shatavari.
Oh, so
And
good.
it within 2 cycles, usually we'll see improvements in estrogen levels. For her, like hers was so low, it took like 4 cycles,
Yeah.
but it's a really great intervention. It's really specific to support increasing estrogen. So
Mhm.
please don't everyone go out and get this before
Yeah.
an evaluation.
Work with your
Like
doc, of
big
course.
disclaimers, it will increase your estrogen
Hashtag
levels.
not medical advice, right?
But I love that one. It's a very reliable go-to for us to help support the estrogen when it's off or out of whack. We see a lot of times when even luteal phase estrogen is low, and we'll use the same intervention. We'll just use it in the luteal phase instead of the follicular phase.
Okay.
So, yeah, that tends to be it for us. Like, let's just address the estrogen. The other piece, I guess, is really looking at food intake,
Mhm.
high fats. Are you getting enough fatty acids, cholesterol, vitamin D? Like, do you have the precursors to actually making the hormones that your body needs? Estrogen is like a downstream hormone. So if you didn't have enough to start with, and then your DHEA is low and testosterone is low,
Yes,
estrogen's even going to be lower, right? Like
totally.
you need all of those preliminary steps. So any hormone support along the way will support estrogen. For this person that I was talking about, her DHEA was also flatline. Not a surprise. Like she was on a low fat diet, right? So you can just trace it, keep tracing it all the way back to this is a long-term lifestyle shift that she needed to eat more fats, she needed more healthy fats, support the DHEA levels, and then that was going to also downstream impact estrogen in the long run.
Yeah, I like how this is what we do. We're just peeling back the layers of the onion, one layer and then the next and then the
Yes,
next and getting to
yes.
the bottom of it. And I mean, I think you said when you did your Dutch testing, you saw that this patient had some cortisol stuff going on, it sounds like. So of course, if you have elevated cortisol,
Yeah.
that is going to impact your sex hormones. So it's lifestyle and it's nutrition and it's all these pieces.
Mhm.
Um, I mean, you said this, but I'm just going to say it again in case anybody is, I'm just going to highlight it. If you see FSH, LH, estradiol on the same lab order as the serum progesterone, That's wild. These things need to be measured at different times. So estradiol, LH, FSH, AMH, we're going to do all that on cycle day 3. And then progesterone is going to come a week after you ovulate. And so my call to action is if you get a lab order from your doc and both of these hormones are on there, please ask them, what cycle day did you want me to go? So that you can have precision in your lab order, right?
And if your doctor says it doesn't matter, red flag.
Red flag.
Like, are they actually a fertility specialist?
Hormones
Should
are
be the
cycle day
question there.
specific. Yes, thank you so much. Okay, so you're going to start with those foundational labs. That is exactly what I was hoping you would highlight because those are so important. What else is on your lab order? Anything else we should really be thinking about?
Yeah. So other things to consider are going to be, again, on the foundational level, red blood cells, white blood cells, iron, thyroid, um, insulin, blood sugar,
Yeah.
and homocysteine. So those are like the big panel on blood tests. And I
Yep.
think that's a really good starting point. In addition to that, I think if someone has had unexplained infertility for many years, then we're really saying, okay, what else could be going on? And we can go one of two ways. We can either have a deep conversation with you and figure out the exact test to order, or what we've been noticing is that there is a group of tests that we like to see on most women that help us put this picture together. And right now I'm focused on women only. Men are an equal and important piece, and I will not forget the men.
Yep.
So on the female side, being able to see the Dutch cycle map and Dutch complete really helps. For those of you that are unfamiliar, it's basically like a urine hormone test. You're doing the collections at home for an entire cycle. It's not a spot test. Do it for an entire cycle, and it shows the map of estrogen and progesterone, what's happening with those two hormones through the entire cycle. And then it also shows the metabolism of estrogen, progesterone, and testosterone. So you get to see the big breakdown of the sex hormones and of course we'll see cortisol, melatonin, just all of the different areas that are impacting fertility, even if they're not a direct correlation, right? Everyone's like, yeah, I'm stressed, or I'm not stressed, I'm fine, I'm fine, I'm fine. But the labs show a different story. So I like the Dutch test a lot. The other test that we do frequently is a nutrient assay. So like a functional assessment of nutrients to get a sense of are there some blaring deficiencies that are telling your body, A, that you're not safe, or B, that you don't have the right nutrients to help bring another human life into this planet. So we want to know what those nutrients look like. And the last one is relatively new, but for the last year and a half, I've been suggesting that we test everyone, and that's the vaginal microbiome.
I knew you were
And
going to say that. I was hoping you would anyway.
I love it because initially when we first started testing, we would just do it based on symptoms. And so many women don't have any symptoms. They've never had a UTI, they've never had a vaginal infection, but their microbiome is so skewed. And there are what I like to explain as like anti-fertility microbes that can be in our reproductive system that are just making it very, very difficult to get pregnant and stay pregnant. So if those are present, then that's an immediate cause of fertility issues. It's no longer unexplained. It's as simple as the microbiome in your body is basically saying, do not get pregnant. And if you get pregnant, the immune system is attacking that embryo very quickly to make it not happen. So the microbiome test has been a game changer, really. Like as soon as we started testing everyone, we're like, oh shit, this is like way bigger
Who
than
knew?
we anticipated. Yeah.
Yep.
So,
That
so
is an
those are the
all-star
ones.
lineup.
And then on the other side, on the male side, I think unexplained infertility often is being put on the woman, but on the male side, like, have we really truly evaluated this man? And the number of times that men hear, "Oh, your sperm are great." And I literally talked to a guy 2 days ago. His numbers were great. So count was like 129 million.
Wow.
Morphology was 2%, and motility was like 40%. So motility and morphology are extremely low, but he's being told your sperm are great, you're not the problem. And when it comes to natural conception, and by natural I mean without intervention, we're really like, that needs to be way different. And I'm like, I basically equate it to like, if your sperm production factory has been outsourced to China and it's putting out shit quality sperm that is not going to be adequate to fertilize a high quality egg. And it no longer is unexplained. It's male factor fertility issues. So it's mind-boggling to me how many men are told like your sperm are great. And of course, they're going from the number side, right? So they're like, oh, you have 129 million. So even if only 2% of those are normal, healthy, viable sperm, you still have a high number. From our side, the sperm have to get through the cervix, which kills millions, millions and millions of sperm. So let's say like 5 million make it to the egg, potentially. That's a really high bar. And they try to fertilize the egg, and now the morphology, the head or tails of those sperm are not adequate, and they don't have the right enzymes and the right shape to break it through the protective barrier of the egg. They will never fertilize that egg. So yes, in the context of reproductive endocrinology, where you are going to do IVF as the intervention, and they have the potential to like filter out the not so great sperm, and you keep only the good ones, and then they are being put in a petri dish in an environment where they don't have to find the egg.
Controlled.
It's very controlled. You have way different levels of bypasses for sperm not being great. It's a very different environment than when you're trying to do this with sex as the way to conceive. So it like the bar for sperm just has to be way higher. And then like general health. So let's suppose everything was great on the sperm. Motility for us, we like above 75%, and morphology, we like around 10% is great. We'll take it. Anything higher than that, yay. But most guys are not even at 5%, and they're being told their sperm are great. So we have a really big discrepancy between the evaluation that a man goes through in a reproductive clinic, where they're assuming that a majority of the people that are there are going to move forward with IVF. And then the people that we see that are absolutely not. They're like, what other options are out there? They're like woken up to the fact that they want to do something different. And maybe they don't want to go to IVF, but they've already been told that their sperm are great. So they're coming in with the belief of like, oh, it's me, not him. Then they're already at an unfair disadvantage.
One of the most common questions I receive in my inbox is, how can I support my egg quality? Whether you're thinking about fertility in the future, you're trying to conceive for the first time, or you're preparing for IVF or egg freezing, caring for the health of our eggs is one of the most important ways we can support our fertility. To optimize my own egg health, I've turned to my partners at Needed. Their egg quality support supplement combines 4 targeted and optimally dosed antioxidants to improve egg quality. Plus, they also have a CoQ10, which I'm always talking about as a powerful antioxidant and mitochondrial support. Remember that an egg cell or an oocyte takes 3 to 4 months to mature before ovulation, and this is a really meaningful time to support egg health through nutritional support. Needed egg quality support contains therapeutic levels of targeted antioxidants and was curated by a team of fertility-focused practitioners and researchers. If you're thinking about getting pregnant in the next year, I highly recommend adding needed egg quality support to your supplement routine. Head over to thisisneeded.com and use code Functional Fertility for 20% off your order. That's thisisneeded.com and use code Functional Fertility for 20% off your order.
Ooh, there's so much juicy information to dive into here. You reminded me, I mean, I try to approach this with a lot of like care and graciousness because I know everybody's on their journey and it's hard and you have probably multiple providers telling you different things. But I had a couple recently where the husband brought in a semen analysis, zero morphology, like none of them were normal. And the wife was being treated with ovulation induction. And I just had to we have to have a pause moment here because these medications, they do have side effects, right? Like it's not completely benign. And the fact that there's no normal sperm, can we just take a moment and work on that before we move on to these higher order interventions? And it really plagues me. And I don't understand why no one is calling these things out. And I guess that's why we're doing what we're doing, to try to build awareness about it, because it's really frustrating.
Yeah. And the sad piece of that is like, they're going to put her through several rounds of ovulation induction. Oh, sorry, that didn't work. Now it's time to do IVF. They might even do several cycles of IVF. It's heartbreaking that we don't have better checks and balances in place to have people being guided in the right way. And I'm a believer that everyone has their own path and not everyone needs to go through the natural, holistic, functional route. Right. But like, let's be realistic about it, right? Similarly, I had a woman whose AMH was 0.3, which is extremely low. The research on AMH is above 1.06, IVF is great. Below 1.06, IVF not so great. So she's 43, AMH is 0.3. She's being told IVF is her only option and she should do cycles as quickly as possible. She consults with me and I'm like, well, I can only speak to what the research says, which is under 1.06, IVF is not the best option. And have you optimized egg quality? Are you guys in a place that you're going to like have the best chance for this IVF cycle to even work? And in the process of doing the improvements, she gets pregnant. And it, like, of course, not a surprise to us, but she was like, oh my God, I was told IVF was only my only option. And I was like, well, IVF was not the only option. And it was actually the worst option possible because your AMH was so low. I think once people start understanding, like, IVF is a really great option when you have tons of eggs, but it's a numbers game, right? It's the more eggs you have, the better chances of success. But when your AMH is low and your doctor is saying IVF is your only option, that's where you pause and say, actually, is that true? And wouldn't I have a better chance at natural conception if natural conception only needs one egg, right? It needs one good egg, one good sperm. We need lots of good sperm. One eventual that fertilizes. Yeah. So if we're really like breaking it down to who's going to have the best chance at success in whichever route, and I always like to frame it in that context. Like, there are people that are going to have better IVF success than natural. So yeah, let's just like go for the thing that's going to have the best chances of success instead of like being feared into something that isn't actually based in anything. It's not based in reality, right? Another woman I probably talked to her about a year ago, but she stays with me because she's 32 years old. They had been on the journey for 3 years, 9 IVF cycles in 3 years at 3 different clinics. her AMH was really good. They were getting like 20 to 25 eggs in every retrieval, but she was fertilizing maybe one or two. And the quality of those embryos was really low. So she's going through every single cycle. This was the outcome. This is how many they retrieved. This is how many fertilized. This is how many made it to day 3. And she knew all the numbers for 9 cycles. And so she's telling me, I'm writing it all down and I'm looking at this thing. And I was like, it's the guy. Have they tested his sperm? And she's like, oh yeah, his sperm are great. I'm like, no, have they done a DNA fragmentation on the sperm? And she started crying, of course. And she was just like, why didn't anybody tell me that this was a thing? They went and tested the DNA frag. And of course, it's really high fragmentation. And she wrote me back and was like, thank you so much. Like, I don't know why 3 different clinics did not raise this as a flag, but it's so frustrating to have this at 32 unexplained infertility diagnosis, been through so many rounds of hormones and cycle after cycle after cycle, but no one is pausing to say, hey, maybe we should look at this other thing.
Yeah. I 100% echo this. I was going to ask you about DNA fragmentation, so I'm glad you went there naturally. I don't know why this is so hard to get just at our local fertility clinics. I'm just doing it through legacy at-home testing now because it's just so much easier to get it when we just don't have to ask anyone's permission. We just order it. But still, when my patients have it and they're getting ready, they're preparing for some type of fertility treatment, they're always told it doesn't matter. And I'm trying to figure that one out of why we have this perception of it doesn't matter when clearly it does matter. This is my segue. Oh, go ahead.
I think there's this rhetoric of it. There isn't enough research to back the DNA fragmentation thing, but we understand that if DNA fragmentation is a reflection of the genetic expression of the DNA that will be passed on to this baby, then the expression of that DNA matters. It matters a lot. And sure, the like what everyone keeps saying in the reproductive world is, oh no, there isn't enough research. There isn't enough research. I don't understand. I'm like, well, yes, but it's there's a lot of like controversies in the fertility world that I think there is some research, but there's also the missing common sense aspect that I'm like, that doesn't track, right? Like, where's the common sense that would go into like you creating a clinical decision based on research? Like, I don't care what the research says, like you're thinking through this yourself. And like, what do you come out with on the other side that went through this thick head of ours that says, well, it just makes sense, right? Like, I don't know.
Makes sense. Thank you. I guess that's what I was trying to, the language I've been trying to find. It's like, we all went to school and we learned about DNA, and we know that when DNA integrity is poor, that's a problem on so many levels. And yes, there are DNA repair genes, and our oocyte is going to repair those to some extent. But if there's a lot of DNA fragmentation, that repair capacity only goes so far, right?
Yeah, and that's assuming that the genes from the female are the highest and best that they can be, right?
Mitochondria are healthy, plenty of antioxidants, all of that.
Like, it's a both and equation, and the lower the fragmentation on the male side, the less work the female side has to do to compensate for it. So yeah, I just feel like I've heard everything from like diet doesn't matter to sperm don't matter to egg quality doesn't matter. Like, what are we talking about?
This is the perfect transition into my next question because we're already talking about sperm DNA fragmentation, and I want to direct us towards recurrent pregnancy loss for a moment,
Mm-hmm.
because this is
Mm-hmm.
also an area where I feel like the DNA fragmentation is important. Will you tell us a little bit about how you approach the laboratory piece? Is it the same labs you're using for unexplained infertility? Are there different things when they're getting pregnant, but they can't stay pregnant?
Yeah. So the workup is similar but slightly different. There's a couple of additional factors that we have to consider in recurrent pregnancy loss. A few of them are on the male side. So we've talked about the DNA frag, and specifically, there is research that higher DNA fragmentation will lead to a higher chance of pregnancy loss in the woman. So that exists.
Mm-hmm.
The other factors that I've seen repeatedly are hyperhomocystinemia, so high homocysteine levels, and another indicator essentially of epigenetics and
Yeah.
methylation and detoxification. So when that is very high, the methylation piece isn't working very well. And that hyperhomocystinemia on the male side can also affect pregnancy loss in the woman. And the third one is blood sugar levels and insulin dysregulation in the man, also affecting the female side. And here, the question becomes why? Like, why are these things on the guy's side affecting the female? And the reality, at least from what I know, I haven't seen any research otherwise, is we don't really know the full answer. We don't know what the mechanism is. We don't know what's being transferred that causes that pregnancy loss in the women, but we know that it's happening. And that's enough to get us started. That's enough to be like, let's make sure we're testing these guys. Let's make sure their liver is functioning well, they're methylating properly, and their blood sugar is regulated. Like, seems like basic things, but a lot of these guys have pre-diabetes, diabetes, undiagnosed, under the radar. We have a guy recently, he's like 38, and he is super fit, like super healthy, takes care of himself, is hiking like once or twice a week. He's doing all the right things. Yet his hemoglobin A1C was like 5.8. We did all the dietary interventions, did not shift. It went up. It went up to 6.
Oh,
And I was like, what? It was like not making sense. So we did more interventions, and now it's finally 5.4, which is great. But for a little bit we had a freak out. Like, what is happening? We just made better dietary choices and it went the opposite direction, not understanding. Um, but that alone, and the woman has had 3 pregnancy losses, and she has factors on her side, but those things in the guy's side are certainly having a role to play in whether or not she's going to carry to term. And then on the female side, we also want to look at autoimmune, Hashimoto's, Graves, antibodies in general, so anti-nuclear antibodies. And then uh, traditionally the panels will have like clotting factors and things like that. We test it sometimes. So we will if a woman's had multiple losses that we can't explain through other things, but we don't always need to test it, because if you have antibodies and you have these other things happening, then addressing those factors is going to make for likelier chances that you have a healthy pregnancy and carry to term.
yeah, it's super interesting hearing you talk about all the things on the male side. And I'm just in my mind, I'm like, oxidative stress seems
Yes.
like this
Yeah.
connecting factor, even if we can't figure out what exactly the mechanism is.
Hmm. Yeah.
Hyperinsulinemia, hyperhomocystinemia, all these things like just generate so much oxidative stress,
Yes,
which impacts the
absolutely.
health of the
And
sperm.
so what I was reading this paper, and it was like 200 mitochondria in the tail of one sperm.
Yeah.
Like one spermatid has 200 mitochondrial cells. and it needs that amount of energy to be able to like move its
Swim.
way to the, like, it's not very far, right? Like, I just thinking about like the physical distance, but these are like microscopic sperm that have so much energy production locally to be able to transport themselves to the egg. So if these mitochondria are dysfunctional or they are putting out the wrong compounds, meaning they're like malfunctioning, creating more oxidation rather than having the antioxidants to deal with that oxidation, then locally that sperm is damaged and is not going to make it to where it needs to go. And it's certainly not going to fertilize an egg and make it a healthy future baby.
A couple weeks ago, I said on Instagram, like if you have insulin resistance, you don't have unexplained infertility, right? And people were like, "What are you talking about? I have insulin resistance and I've been diagnosed with unexplained infertility for years." And I'm like, "Well,
Yeah.
I disagree."
Yeah,
But now with what
absolutely.
you're saying, it's almost like if your partner has insulin resistance,
Yeah.
you
You
don't
don't
have
have
unexplained
unexplained.
infertility.
Yep.
That is a real mind shift there. But yeah, we got to think through all the parts. So I'm just wondering, like, when you're working up patients for either unexplained infertility or recurrent pregnancy loss, and you're looking at labs, I'm sure you've looked at just thousands of lab reports over the years. What are some themes that you find? You mentioned DHEA. I see low DHEA in a huge percentage of my patients. What are some other themes or patterns that you see over and over and over?
The one that's probably not surprising is the cortisol, right?
Yeah.
Like always cortisol issues. Most people are flatline cortisol, meaning their body has decided, I'm done. Like, I am
And
not
not.
doing this anymore. Cannot, not getting out of bed to produce cortisol anymore. And that is unfortunate because cortisol gets a bad rap most of the time, but we need cortisol. It's the body saying, "Hey, time to create and be alive in the world." And if we don't have that message going out, or if that message is so short-lived and then it crashes, like for a lot of women, they'll have like a morning cortisol rise that's very nominal, and then they'll flatline, and then it'll be low all day long. And if that's the case, it's like the body is in survival mode. There's no thriving. There's no, like, I have this abundance of vitality to pass on to a child that's literally going to grow inside of me for 9 months. But instead, I am like just barely living. I do not have excess energy. I do not have excess resources. I'm trying to conserve. And if my state is conservation and protection and survival, then no way is it time to reproduce. So I think that's a really big one. And that's a pattern that gets a little bit pushed to the side because so many women will be like, oh, I have a little bit of stress, but it's fine. I'm good.
We're acclimated to it.
We're acclimated. We're also like, this is long-term stress. So it's how your body has been functioning for many, many, many years. And if our pattern has been go, 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 do for a lifetime, for 30, 40 years, of course, our body's like, I'm done. I'm good. Like, do I really need this hormone? Nah, I'm good. I'm surviving, right? I'll just put out enough to like survive and get through
The
life.
bare minimum here.
Yeah. Yeah. So it's like the high achiever women, so many of which are people. And I love working with them. And we all have this persona of doing too much, finding value in overdoing and overachieving. And like I have to create value by what I do in the world. And we've pushed ourselves so hard that internally our body's like, well, you're going to keep pushing, but I'm going to need to chill out. Like I need to not do so much. So it starts trying to figure out, where do I conserve? And fertility is one of the first places to conserve energy. Like if my body is in threat mode and I need to survive, what can I turn off? I can't turn my heart off. I could maybe turn my digestion off. Like I don't really need that. I could maybe turn off reproduction, because definitely don't need that. So like the symptoms that we often start experiencing are in a hierarchy. So reproduction is going to be the first to go. Then it's going to be digestion, because as much as we need food, we can survive without great digestion. So the body's like, maybe I'll turn that off. Maybe I'll just compromise a little bit,
Battery
right?
save mode. Yeah.
Yeah. Then it's the adrenals and thyroid are going to come next. So like our body is incrementally showing signs of shutting down and conserving energy for survival mode. So we're going to see those patterns, and the hierarchy is really the level of turning off also needs to be how we turn things back on. So a lot of people will be like, well, can't you just give me thyroid hormones? Because my thyroid's low functioning. And I'm like, yeah, but that's
You gotta go
not
a step back.
fixing. Yeah, like we got to turn all of these systems back on in a hierarchy of need. Like your digestion has to come back on first. Otherwise, whatever we do for the thyroid is literally a band-aid, and it's not fixing what's happening under the surface. It's not telling your body, hey, it's safe to actually heal your thyroid. So yeah, sorry,
Wow.
that was a very
Okay.
long answer.
That was very good. Be right back. Going to go order my cortisol profile right now. A little scared, but let's take a look. This has been such a juicy episode. Dr. Aumatma, will you tell our listeners where they can find you?
Absolutely. I like to hang out on Instagram. So at Holistic Fertility Doctor, send us a message, send us questions, whatever. Happy to chat there.
Awesome. Well, let me give some thank yous, because I have so much gratitude to our listeners. Thank you for tuning in and choosing us as a trusted source of fertility information. To our show's producer, Paola Martini, thank you for making my podcast dreams come true. And to you, Dr. Aumatma, thank you so much for the work you do and for the insights you shared today. It's always a pleasure to chat with you, and I look forward to seeing you again soon.
Thanks for having me.
See you next time, everyone.
Did you love this episode and want to hear more? Head over to drkaleawattles.com/podcast, where you can find more episodes on all things fertility.